So the head will hang like this. How long to wait? Till the hairline is visible, but never more than 1 minute. You are not allowed to wait beyond 1 minute, because if you wait more, it will get asphyxiated. If hairline is visible, then you will have to help delivery. Now the mother is not able to deliver unless it is very small. So delivery of the head, there are 3 methods, and this is very important for your fiber. If hairline is visible, what will you do? We will deliver by what is called Burns-Marshall maneuver. So this is the mother, and this is the baby. Suppose the baby is hanging in front of you. These 3 fingers hold the ankles, thumb, index, and the middle finger. Hold it, and with the other hand in the lower abdomen, put gentle pressure to cause flexion of the head. So suprapubic pressure by the assistant. An assistant is needed also. So in the prerequisite you will write on assistant. The assistant will give suprapubic pressure to promote flexion, and you will hold the kid, and with the other hand you will give some support to the perineum. Gently pull the fetus. No extra force. Gently pull the fetus and gradually lift up towards the mother's abdomen. The fetus is coming out. Again I repeat. Assistant gives pressure. With 3 fingers, hold the ankles. With gentle stretch, pull it up in a wide arc towards the maternal abdomen. The baby will be out. So this is called Burns-Marshall maneuver. This is allowed only when the hairline is visible. Hairline is not visible, then what is called malar flexion, shoulder traction. So the baby is like in front of you. Horse's back. But allow the baby to sit like riding a horse, putting 2 legs on either side. These 2 fingers should be kept on the malar eminences. Left hand, left fingers on the malar eminences. On the right, the longest finger in the subocciput, and the fingers on the other side on the shoulders. These upper 3 fingers help to cause flexion, and the lower 2 fingers on the shoulder gives traction. That's why it is called malar flexion, shoulder traction. In exam, we will have to show the location of fingers. So you can see malar fingers. So it's riding on the horse, and put the fingers like this, and then suprapubic pressure by the assistant, downward traction followed by maneuver like Burns-Marshall. So this method is called malar flexion shoulder traction, and there is a term, name of the obstetricians, Mauricio Smelly Vet. Remember this, because the examiners are fond of asking the name. If you don't know the answer, no marks will be deducted. If you know the answer, marks will be credited. So Mauricio Smelly Vet. Third is, if hairline is visible or hairline is not visible, you may apply forceps. So alternative to the other 2 methods, forceps to the aftercoming head of breech. Now the forceps is applied not like this. It is wrapped with a towel, lifted up and held by the assistant. Blades are applied from below, and it is gradually delivered. So there are 3 methods of delivery of head: Burns-Marshall method, Mauricio Smelly Vet or malar flexion shoulder traction, and forceps. So this you have to write in your theory. Long question. Next, breech extraction. That is done. All these steps, all these manipulations are done, but very rapidly. due to some emergency complications, and it should be done in the OT under general anesthesia. Then only it will be called breech extraction. So emergency complications like cord prolapse, bleeding, or acute fetal distress. If you take too much of time, the fetus will die, or due to bleeding, the mother will succumb. So in that case, we will have to deliver quickly. So due to some emergency indications, if the baby is delivered by following the steps of assisted breech delivery in a quick way in the OT under general anesthesia, then it is called breech extraction. So always in the OT, always under G. And the last one is destructive operation. Big head, hydrocephalic head, stuck. Perforate the head, reduce the size, and deliver. So the methods of delivery of breech: CS, cesarean section, spontaneous breech delivery, assisted breech delivery, breech extraction, and destructive operation. So this much I am recapitulating. Breech, podalic extremity presents at the lower pole of the uterus. Incidence at 30 weeks 25 to 30%, at term 3 to 4%. Types: complete, incomplete. Complete means flexed, multi. Incomplete, frank breech or extended breech, common in primary, rarely knee and foot link presentation. It may be complicated breech, that means breech plus obstetric complication, uncompleted. Diagnosis: breech, hard round palatable mass in the fundus and buttocks, that is firm, irregular, non-palatable mass in the lower foot. Fetal heart sound in case of frank breech, spino-umbilical line; in case of flex breech, high up on the sides of the umbilicus. Confirmation by palpating the structures of breech. Then causes of breech, you remember from the story: prematurity is the commonest cause, contracted pelvis, multiparity, and then all other points like placenta previa, cornofundal insertion of placenta, polyhydramnios, oligohydramnios, short cord, fibroid in the uterus, congenital malformation of the uterus like septate and bichondriate uterus, congenital malformation of the baby, any muscular dystrophy or neurological disease, or if there is intrauterine fetal death. Next is mechanism of labor. For buttocks, 4 steps: descent, engagement, internal rotation, lateral flexion. For the shoulder, same plus restitution. For head, descent, engagement, flexion, internal rotation, and delivery by extension. Next, management, complications of breech delivery. Maternal complications: injury, bleeding, infection, peripartum, etc. For the fetus, mention birth asphyxia first, then prematurity, intracranial hemorrhage, then injury to different other structures: skin, soft viscera, bone injury, dislocation, nervous injury, and stomach muscular injury. Increased perinatal mortality and mortality. Management is antenatal management is called stenocephalus bursa. It is indicated under 2 headings: one is breech, one is shoulder presentation. And time of version is 36 weeks onwards. It should be done after admission into the hospital. Contraindications: remember the causes of breech along with some other points like elderly primary gravida, bad obstetric history, any obstetric complication, Rh negative, relative contraindication. Then complications for the mother and the fetus: there may be rupture uterus, retroplacental hemorrhage, that is abruptio placentae, cord prolapse, premature rupture of membrane, preterm delivery, and intrauterine fetal death in 1% of case. Then what are the failure rate? Successful in only 60 to 80%. What are the advantages? Avoids complications of vaginal breech delivery. It helps to avoid complications of cesarean section and anesthesia. Treatment: antenatal management I have told, stenocephalic version, internatal cesarean section. Indications you will have to remember: baby weight more than 3.5 kg, less than 1.5 kg provided neonatal care facility is available. Fetal growth restriction, hyperextended neck, knee presentation or foot limb presentation, breech with any other obstetric complications. And spontaneous breech delivery, delivers spontaneously. Assisted breech delivery, help in different steps. And some prerequisites to be remembered, that is when to shift, when to make incision, what are the instruments to be kept ready, neonatal and maternal sets, for the personnel to be ready, obstetrician, assistant, pediatrician, and anesthetist should be kept informed. Then delivery, step by step, helping delivery of the buttocks, if necessary sometimes groin traction, helping delivery of the shoulders, helping to find out the position of the umbilical cord, and delivery of the head by 3 methods. One is Von Marshall maneuver, one is Mauritius Merivale, third is forceps to the aftercoming head of breech. Other methods of delivery, breech extraction, emergency indications, and destructive operation, hydrocephalus. So that's all about breech. হবে বাড়ি গিয়ে পড়ে ফেলবে। আর একটা টপিকস থাকলো, একটা দিন টাইম দেবে